All right, you want to test me?
I got you coming in here.
Loud enough?
Let's see. We have to start in a few minutes. I got to do something.
Yeah. Yeah, you have to play with that.
Working now?
If you want to go ahead and get up on there, take them in and see if we get them all in there anyway.
Should I introduce myself? I've got a cable back here that I'm going to trip over.
I don't think you hold still.
You have to wrap it around my leg. Will do. Well, good afternoon. Thank you all for coming. My name is Ron Franks, as you probably can tell from the material being distributed. I'm up here from Mobile, where I serve as the chair of psychiatry at the University of South Alabama in the College of Medicine. And I got contacted a couple of months ago about the possibility of coming and talking to y'all. And we looked at a couple of different topics. And the one that I thought might be of most interest to you is what constitutes about 70% of the referrals I get from various physicians and others throughout the community. And so we'll get to that shortly. But first, I thought I would tell you a little story. Dates back to a number of years ago when my son was about 6 years old, getting ready for school one morning. And of course, I was reading the newspaper, solving a few of the world's problems, and my wife is running around trying to get him ready and fixing breakfast, etc. And he's tugging on her, wanting the answer to some question. Finally, in exasperation, she turns to him and says, "Why don't you ask your father the answer to that question?" And he looks at me and says, "I don't want to know that much about it." So I'll try to remember that today as we go through the talk. And hopefully you will find that it's more of a discussion than a lecture, so that it has more meaning for you. And I've sprinkled a few cases in the presentation for us to raise our hands and see what of the various options you might choose for the patients. And for those that are not in a medical field, a couple of definitions that I'll use throughout the presentation. SSRI is for an antidepressant. The typical one of that group is Prozac, Zoloft in that group. SNRI is also an antidepressant. And the typical ones in that are Effexor and Cymbalta, maybe names that you've heard. And so you'll see those abbreviations throughout. I understand we have a few chaplains in the group, and that will hopefully help you keep pace with what we're talking about. Now, importantly, I have nothing to declare. I'm in nobody's pocket, as far as I know. And so the discussion today will include a lot on medications, as you can tell from the title. And there'll be some off-label recommendations, but none of that is supported by any drug company. This is all based on research articles and then supplemented with my own experience. Today we will cover three main diagnoses. Two types of depression that are often problematic that you will see in your practices. Three types of anxiety and early dementia. And we'll get to those shortly. And what you will see with your handouts is three sections. The first is the slides, which are evident to you as duplicating this. Right behind that is the condensed version of the slide, where they don't have the various builds, won't have the cases in there. And that's the takeaway. And for those of you that want a reference of the various medications that you probably are using in one time or another in your practices, I've put together the most common ones, and I've put the usual starting dose and the usual maximum dose. And so that can serve as a reference for you, and often is a lot more convenient than searching through Hippocrates or whatever other source you use in terms of medications. Now, for those of you that want just a little bit of history about the medications that we use in psychiatry or for psychiatric illnesses, if you go back about 40 years, we were all very concerned about norepinephrine in the brain, and we came up with what were called tricyclic antidepressants. And we used those a lot for more severely depressed patients. A lot of side effects, and most patients would not tolerate them for very long once their depression got better. Then the attention started to focus on serotonin in addition to norepinephrine. And so the Prozac drugs came along, and they are much more tolerable for patients who are usually willing to stay on them longer. Some drugs work both on norepinephrine and serotonin. Those are the SNRIs. And now it looks like we now are going to be able to focus on glutamate, which is a brand new set of drugs coming out. Ketamine is one of the ones you may have heard something about. And over the next 10 years, my hunch is we'll have a series of antidepressants that work with patients where glutamate is the neurotransmitter that's a problem. All right, enough psychopharmacology. We'll move on then to practical things. A few assumptions for us as we get started. If you have a patient that you are not seeing a response, depressed patient, anxiety patient, the first thing that I'd recommend is you go back and make sure your diagnosis is accurate. Some patients that talk about anxiety actually are suffering from depression and vice versa. And so gathering a more accurate history is one way to make sure that you're using the right medication. And then, for those patients, particularly where they've had an acute stress in their life, psychotherapy can be very helpful and augment the antidepressant. And one of the things that you've probably heard quite a bit about is mindfulness, and related to that, meditation. I've included in your handout 2 different websites that I probably distribute to maybe 20% of my patients that teaches them through YouTube the techniques of meditation. And I recommend that they do it twice a day for 10 minutes each time initially as they get used to it. And then they can reduce that to a couple of minutes once or twice a day as they, quotes, reset themselves through the use of meditation. Now, to tell you how popular this is becoming, you can ask Alexa to guide you through meditation. So it won't be long. Artificial intelligence will be replacing me and be giving this lecture in a couple of years. The other thing, which now has been documented over the last 3 years as being almost as effective as psychotherapy, is exercise. Now, for those of you that use Fitbit, that's not quite the same. It needs to be a block of at least 20 minutes. And during that 20-minute period of time, the exercise doesn't have to be running a marathon. It can be walking the dog, some type of physical exercise that is concentrated in at least a 20-minute period, which seems to release internal antidepressants. Now, even more importantly, within the last year, large study showed that of all the things that can be given to help delay the onset of Alzheimer's disease, if you're destined to have it, is exercise. And it would appear that the human body determines whether it's necessary to continue to exist. And if you're exercising and becoming fit, it's one way of telling your body you're still relevant and you need to be here. And the exercise is one way of stalling not only cardiac disease, which we are well aware of, but now well proven for depression and for stalling the onset of Alzheimer's disease if you happen to be in that category, where you're going to end up with it at some point in your life. Now, the other important history to get is use of alcohol, other illicit drugs, marijuana. And believe it or not, the fastest growing group of alcohol abusers are patients 60 years of age and older. And surprisingly, marijuana is becoming very popular with that group. It's hard to believe, but indeed, that turns out to be the case. So collecting that history is important, and it probably will surprise you, some of the patients that confess what they're doing. And so if you're prescribing an antidepressant, while also the patient's having 4 or 5 drinks a day, you might as well have them throw the antidepressant down the drain, because that amount of alcohol is going to drain all of the neurotransmitters that you're trying to increase with the antidepressant. Now, one of the things that I would caution you, if a patient has some passive thoughts of suicide, or they think maybe I'd be better off if I weren't here, that's not uncommon and usually not reason to refer the patient. If they're more actively suicidal, if they've experimented, or if they have some specific plans of what they might do, I would suggest that that's a patient you want to refer to a psychiatrist for further evaluation. It's really, if you're not used to treating that type of patient, the risk is not worth it. And these are obviously very seriously ill patients, and ones that may require a very comprehensive approach. Running a PDMP is important, of course, because many of the patients that have depression might be secondary to overuse of opioids or benzodiazepines that they may not have revealed to you as you collect the history. And also, when you're getting ready to use medication with a patient, what I explain to them is that the medication will reduce the intensity of what they're feeling, reduce the volume, so to speak, of the emotions, and that will make it easier for their cognitive part of their brain to be able to make good decisions for themselves, rather than right now when they come see you, where it feels like the emotions are making the decisions or driving the decisions, as opposed to their cognitive skills. And so that helps them get a better sense of what the medicine can do and what it can't do. All right, well, let's talk about 2 types of depression that you probably have seen and struggle with in your practices. The first is for the patient who initially responded to an antidepressant, but now the depression has come back. And you're scratching your head wondering, why is that? Their lives seem to be pretty much the same. There's no new stresses. Well, phenomena that has become increasingly evident with the antidepressants is that any period of time from about 6 months to 2 years, those that respond to the antidepressants, a good 40% or more, will become tolerant to it. And that tolerance is kind of interesting, because if they are off that antidepressant for 3 or 4 months, they will become responsive again to it. But when they come to see you and say, you know, this depression has come back, I am just not feeling like myself anymore, or it feels like I did before, the first thing to think of is that they have probably become tolerant. And the first response would be to raise the dose of the antidepressant they're on, if they're not on the usual maximum dose, and that's where that third handout will come in handy. And I usually do that over 2 or 3 increments to get them to that dose, depending on the medication. Sometimes it's going from like 10 milligrams of Lexapro up to 20 milligrams. Now, if they're already at the maximum dose, the next step would be to add Wellbutrin, bupropion, starting at 150 milligrams a day. Now, that's a slight stimulant, but it also will augment the antidepressant. If they're on, let's say, they're on Zoloft and they're on 200 milligrams a day, and it's just not quite getting them back to where they have been in the past. And you can go up to 450 milligrams a day. Now, you have to be a little bit careful with bupropion, because above 450 milligrams a day, you increase the risk of seizures. It's a medication that if you stay below 450 milligrams, they usually don't have problems with seizures unless they have had seizures in the past or some reason due to CNS disease to be subject to seizures. And so bupropion, as opposed to the other antidepressants, about 1 in 1,000 chance of having a seizure with it. Most antidepressants about 1 in 10,000. So it's still a pretty low risk. And if they happen to miss a dose, tell them not to go above 450 milligrams in a day. Now, if that measure is not successful, or if you decide with the patient they don't want to try a second antidepressant, I will get the history of what they may have taken in the past, and if they've been off that earlier antidepressant for 3 months or more, then we'll go back to the earlier antidepressant. But what I have found the most helpful is that start the earlier antidepressant while you're beginning to taper the current antidepressant. And for some patients, tapering over 4, 5, 6 weeks is necessary. For certain antidepressants like Effexor, a longer tapering is required. For others like Prozac, a shorter one is. But in general, if you taper them over 4 weeks, and at the same time you're starting the new antidepressant, usually you'll begin to see a response, especially if they have an antidepressant that worked for them in the past. Any questions on that? Does that make sense? Now, at the same time, often you'll find, of course, with depression, sleep disturbance. And the two drugs that I like to use for patients are trazodone, 50 to 150 milligrams at bedtime. Start with 50. It too is an antidepressant, works on the serotonin system, and it's just sedative enough that usually helps them get to sleep. Mirtazapine also is sedative, but it has a problem with weight gain. And so for patients where weight is a particular issue, then they may not be willing to try the mirtazapine. But it's a little bit more sedating than is the trazodone. All right, well, let's talk about our first case. Let's say a 54-year-old white female, 2 years ago had a CVA, secondary to an unusual coagulopathy. Left her with left hemiparesis and mild to moderate receptive and expressive aphasia. Now, as you often see with post-stroke patients, at least 25% will develop depression just based on the disruption of the normal neurological functioning. And she had initial depression, and it responded to escitalopram, Lexapro, eventually at 20 milligrams a day. After about a year or so, it stopped working for her, and I switched her over to Effexor, venlafaxine, at 150 milligrams a day, working up from 75 to 150. And that worked for a while, about 6 months, and now, as you see, the depression is back. All right, we have 4 options here. So this is a chance for you to get active. Giving a talk right after lunch is pretty difficult, so I got to keep you as active as I can. All right, so option 1. We could go up to venlafaxine, 225 milligrams a day. Who thinks that would be a good approach? Raise your hands. I saw just a little flicker over here. All right, second option. And more than one option is acceptable here. It doesn't have to be only one answer. Taper the venlafaxine while restarting the escitalopram. Who would do that? Ah, here's another brave person. Ah, 2, okay. All right. So far, actually, both 1 and 2 are acceptable answers. So those who almost said number 1, that is as acceptable as number 2. Keep venlafaxine at 150 milligrams a day and augment with bupropion, 150 milligrams a day. Who thinks that would be a good response? Meh. The risk with bupropion with somebody who's had a stroke is seizure. And so while the risk is low, it probably isn't worth taking if you have another alternative, which we have in option 1 and 2. And so using bupropion in somebody that has a potential risk of a seizure probably isn't the best strategy. You could get away with it, but since you have other couple options, I would favor those over that. Last one, refer for psychotherapy to help the patient accept the limitations of CVA. Oh, I can't go wrong with that, right? And now for her, she had psychotherapy, and she said, I don't need any more of that. I already know the limitations I've got, and I don't need any more therapy. I just want the medicine to help me. And I'm sure if your experience is like mine, probably only about 1/3 of the patients will want psychotherapy. They want a medication, and they want the medication to make them better. And fortunately, with a lot of these medicines, they get better. All right, well, let's say this patient that you've treated, not necessarily the one that we use as an example, had no response to the above measures. You've tried bupropion, still didn't work. Now here, you have a couple of options. One, of course, is to refer the patient. But as you have seen more in the past and recently, because Abilify, aripiprazole, has gone on to become generic, adding Abilify to the antidepressant will augment the antidepressant, or if they're on the antidepressant plus bupropion, the Abilify can help, especially if anxiety is a problem. And so usually about 5 milligrams, sometimes as much as 10, will help augment the antidepressant and bring the anxiety under control. Now, if sleep is a particular problem, then quetiapine, Seroquel, makes a little bit more sense. The problem with these drugs, as you may know, is that they introduce a metabolic syndrome. Weight goes up, cholesterol goes up, glucose goes up. And so you got to monitor those, and if the patient has a weight problem to begin with, this makes it worse, and then their depression maybe get better, but they feel terrible because they've gained 15, 20 pounds with it. And these medicines, for reasons we don't quite understand, make the body more efficient in absorbing the calories we eat. So the patients are clear, and I believe them because so many tell me, I'm not eating any more than I used to, but I've gained 20 pounds on this medicine. And so my depression is better, except I'm depressed about gaining all this weight. So for reasons as I said, we don't understand, they do affect the metabolism and make us more efficient in absorbing the calories that we eat. And the most difficult time with these medicines, Abilify, Seroquel, is 11 o'clock at night. The munchies hit. And if they are not careful, they'll pack in another 1,000 calories a day right before they go to bed. And so I caution them about it. And for many of them, of course, they don't want to go on that medication. And so that's when the patient may come to me to be seen, and we'll go back over many of the things that we went over here in this discussion. All right. Any questions about the patient who's depressed that gets tolerant? All right, well, let's go to the geriatric patient who develops depression. Now, you may have seen this, read about it. It's becoming increasingly clear that for patients who have the first onset of depression at age 60 or later, have a very high likelihood of going on to develop dementia. And if you think about it, as the brain stops functioning as well as it should, one of its major tasks is to keep our emotions relatively stable and appropriate to the situation. And one of the emotions that can get out of hand can be depression. Recent study actually came out this week in JAMA Neurology, showed also that disruption in the sleep cycle can be an early predictor of later developing dementia. And if you think about it, one of the things that is very complex that the brain needs to be able to do is regulate the sleep cycle, the various stages and the length of time. So there are some warning signs here, but it's not the end of the world. As I mentioned earlier, make sure that you've assessed for alcohol or marijuana abuse. Again, expecting to be surprised in about 20% of cases. I had a patient that she was drinking about a bottle of wine a day just to keep the depression under control. And of course, it was making the depression worse for her. So for medication for the geriatric patient, like with all medications, start low, go slow. Try to find a medication that's worked in the past if they've been on an antidepressant. I have a slight preference for the Prozac type drugs, Zoloft, Lexapro, over the Effexor, Cymbalta drugs, since they can raise your blood pressure slightly, 5 to 10 millimeters of mercury. Now, this is something that is in fashion, out of fashion, in fashion, out of fashion. Now stimulants are coming back into the realm of treatment. Low doses, methylphenidate, 5 to 10 milligrams, is often preferable to adding another antidepressant. So if they've got a antidepressant that helps them some but not quite enough, rather than adding bupropion or boosting the dose to the highest level and exposing them to higher or greater side effects, methylphenidate, 5 to 10 milligrams once or twice a day, for this group can really open them up and make them feel so much better. And we'll go to a case here in a couple of minutes. Naturally, you want to avoid a dose after 2 o'clock, since that may interfere with their sleep. And the side effects are pretty minimal, methylphenidate at this dose. All right, let's go to a second case. Mr. B, 69-year-old, retired, white male with a past history of coronary artery disease, 2-vessel stent, no current cardiac symptoms, mild hypertension controlled with lisinopril, and a 3-month history of mild to moderate depression, decreased energy, insomnia, decreased appetite, anhedonia, irritability, no cognitive decline through my testing as well, not suicidal. He was placed on Cymbalta, 60 milligrams a day, and he got to about 75% of his normal self. And so, Doc, I'm just not quite where I want to be. So we have 4 options here. More than one of these is acceptable. Who thinks we ought to bump the Cymbalta up higher? All right, 120. Several. That's an acceptable answer. You begin to see declining benefit once you get above 60, but 120 is the maximum dose and certainly an acceptable approach. How about tapering the Cymbalta and concurrently starting him on Prozac? Who would see that as the approach they would take? All right. Again, acceptable. It's a little bit uncertain, since he's not been on Prozac before, whether he could get back to the 75%, but it's certainly within the acceptable protocols. Augment the Cymbalta with bupropion, 150 milligrams a day. I hope I haven't scared you about that after that last case. No, that's an acceptable response, and bupropion is a slight stimulant. It's not as strong as methylphenidate, Ritalin, or certainly Adderall or Vyvanse. So that is acceptable. How about augmenting with methylphenidate, 5 to 10 milligrams, once or twice a day? All right. This is indeed what I did with this fellow. He didn't want to risk any more side effects from the another antidepressant. And the 5 milligrams twice a day for him, usually first thing in the morning and then again around noon. And he's back to his old self, playing with the grandkids, arguing with his wife, so he feels pretty good. So the methylphenidate at that dosage, very few side effects, and can give just an added boost to the antidepressant. And as I said, about every 10 years, this is in favor, not in favor, not in favor. But what you'll see in a few minutes when we get to dementia, it's starting to become in favor for that as well. All right, well, let's talk about anxiety disorders. There's 3 types of anxiety disorders that are likely to give you headaches. First, a generalized anxiety, probably the most difficult of the anxiety disorders to help your patients with. Second, performance anxiety, which has a much better response to medication, which we'll get to in a minute. And panic disorder. Well, let's start first with generalized anxiety. This is the most difficult of all the anxieties to treat. It often gets confused with depression. Patients just say, I'm anxious all the time. I just can't seem to get the anxiety under control. Sometimes begins in adolescence, early adulthood, and they are tightly wound. And you can tell it when you walk into the examining room. They often they startle, and the whole conversation seems to be very tense. And they are generally pretty miserable. Now, the usual treatment involves medication, antidepressant, which we'll get to in a minute. But just remind you back about meditation and exercise. And the meditation does seem to help these patients. Now, I'm the psychiatrist for the medical students. So about 25% of the medical students that I see are now doing meditation to help them with their anxiety. Medical students often are understandably a little bit anxious when they start medical school, and we'll get to a couple case examples here in a minute. And the meditation just kind of helps them cool things off a little bit. And of course, exercise, as we talked about before. Now, with regard to medication, the usual approach and most effective for generalized anxiety are the antidepressants, either the Prozac type or the Effexor type. The problem is they don't work very quickly, and they're maybe effective in reducing anxiety 40–50% if they'll work for a patient. You often have to go through a couple of different types, or a couple of different ones before you find one that works. And having to delay 2 to 3 weeks before they begin to see the effect, they kind of get discouraged. But try to keep them from giving up on the medicine. It will tend to improve it, not necessarily get rid of it. Now, for maybe 25% of patients, Buspar will help them. For probably about 50% of patients, Buspar is about like taking a glass of water. Doesn't do much. But for some, it is effective. Now, if you have a medication that advertises itself as having no side effects, you have to wonder, does it have any effects? Now, whether it's placebo or not, 50% of patients that I prescribe Buspar for do have a response to it, and I will use it. And I will try to enhance the placebo response and say, this is effective. Now we're going to start a little slow because it can be very sedating and it can overdo reducing your anxiety. So let's work up incrementally. And so maximizing the placebo effect. And usually within a few days to a week, they will get some benefit from it if it's going to work, if they're in that 25–30%. Now, a little bit more controversial, gabapentin. You've heard a lot about gabapentin being used for just about everything. Well, for some patients where they have generalized anxiety, antidepressant is giving them some benefit, but not a lot, you can try gabapentin. Gabapentin will make some patients overly sedated at 100 milligrams a day, and many of you have seen some patients are on 1,800 to 2,400 milligrams a day of gabapentin and it hardly touches them. So it's a little hard to predict. But in reducing generalized anxiety, I find that 100 to 300 milligrams once or twice a day usually takes the edge off of it if they're going to be responsive to it. And you have to be careful that they don't have a tendency to get addicted to drugs or not abusing drugs or alcohol before considering using this. Now, there are some states, including Alabama, that have talked about should it become a controlled substance. It may in the future. It does have a street value, and so you need to be cautious. It's not anywhere near as addictive as benzodiazepines or the opioids, but it does have that potential. And lastly, the old standby hydroxyzine, again, works for some people. For others, it just gives them a lot of anticholinergic side effects without much reduction in their anxiety. All right. And always you can refer to psychiatrists if they're not responding. Next case. We have a sophomore college student, young woman with generalized anxiety as far back as she can remember. Social settings are particularly difficult for her. She's had no panic attacks and no significant depression. No history of substance abuse, occasional use of alcohol in social settings, but not to excess. She had a good response to venlafaxine, but at the expense of the loss of her sexual drive. So the effexor was lowered to 75 milligrams for 150, but now it's only about 75% effective, and she'd like something else. All right, first option. Again, more than one of these can be correct. Taper the effexor while concurrently starting paroxetine, 20 milligrams a day, which is often used for anxiety. Who thinks that might be a reasonable approach? All right. Yes, that's acceptable. The only difficulty is she's not been on Paxil, so it's a little bit of a chance, but it is an effective drug and may well work for her, and certainly worth a try.
Side effects, sexual side effects.
Yeah, you must be reading my script. It does still have the same risk as effexor in interfering with sexual side effects. Now, number two, with that in mind, taper the venlafaxine and start bupropion, which does not, for most patients, interfere with sexual function. You're not going to do that? Yeah. Well, anybody else? That is acceptable, as is number one, and was considered with the patient. The only risk with bupropion, as I said before, it's a little bit of a stimulant, and for some people with generalized anxiety, it makes them actually a little bit more wired rather than more of an anxiolytic. Slight risk. Now, augment the effexor with 75 milligrams a day, at 75 milligrams a day, with Buspar, 10 milligrams BID to TID. Who thinks that would be inappropriate? Well, that's what was done, and it worked. She was in that 25, it's too late to raise your hand now. She was one of the 25% that did respond to Buspar, and it took care of that other 25% anxiety, and she was very satisfied. I myself was a bit surprised, but it worked. And so that's the regimen that for her. Who would have added clonazepam to her treatment? Probably not indicated. Somebody that's in the college age group. Try to avoid, of course, starting them on a benzodiazepine, particularly with her now having about 75% of her anxiety under control. All right, performance anxiety. Years ago, I was the dean of students at the University of Colorado at their medical school, and after doing the job for about 3 years, I was trusted enough to be given the underground news that about 25% of our students were on propranolol before they were taking their test. And so I had to ask myself, is that a good thing or a bad thing? Well, it works. And a lot of performers use it. It's non-addictive. It's used PRN. And so patients that say, you know, normally my anxiety is not too bad, but if I have to get up and give a speech, if I have to perform in one way or another, if I have to take a test, I'm just petrified. And so propranolol, 10 to 20 milligrams before the event that causes the performance anxiety, lowers the physiologic response so that their brain can function and not be flooded with the effects of the epinephrine and norepinephrine. And so it is effective for those that have performance anxiety, which is different than those that have panic disorder and those that have generalized anxiety. This is very specific to events related to having to perform. Now, there was a study about 10 years ago looking at musicians, and they were being judged by a panel that was blind to whether or not the performer was getting a placebo or propranolol, as was the musician. And the scores given by the judges were actually about 10 to 15% higher for those, the performers that were on the propranolol. So I struggled with what I thought was somewhat of an ethical issue, and now much more comfortable helping particularly students that are in the early stages of their careers trying to perform well, of using this to help them maximize their performance. Now, do be careful that they've tried the propranolol before they go into the first performance situation, because you don't want them falling flat on their face because they've had a hypotensive response to it. All right, another case. This is a 24-year-old single African-American female first-year medical student. No significant past medical or psychiatric history, including ADD, attention deficit disorder. She panics during the first medical school exam, scores a 68 with a passing grade of 70 being required. Not an unusual story. Now panics before every exam, although insists, I know this stuff. Denies other panic attacks. The panic symptoms that she has before the exam are elevated heart rate, decreased ability to concentrate, a little bit of shortness of breath before and throughout the exam. So the options: propranolol, yes, then it worked. Clonazepam, not very good, because you may be relaxed, but too relaxed, and you can't think. So you may fail the exam, but not be worried about it. Lexapro, 10 milligrams a day. Not for performance anxiety. It usually doesn't work very well because their anxiety overall isn't elevated. It just peaks at these events, and Lexapro is not very good for that. Meditation exercises prior to each exam, yes, can't hurt. And that assisted her as well. All right, panic disorder. This is a subset. And these are people that have bona fide panic attacks, usually 1 to 3 a week, often spontaneous, occasionally wake up in the middle of the night, not with a nightmare, just having a panic attack. And some will be around certain phobias or certain precipitants. Others will just notice that they occur and they'll last about 20 minutes, shortness of breath, chest pain sometimes, with a sense of compression of their chest, elevated heart rate, and they usually develop some techniques to try to cool it off. Probably about a third of them will have ended up in the emergency room to be evaluated, and you do want to make sure they don't have supraventricular tachycardia masquerading as a panic attack, but assuming that it is, probably about half to two-thirds of them will respond either completely or partially to a antidepressant. And if that's not sufficient, and you feel comfortable that they're not likely to abuse a benzodiazepine and are not using opioids and not presenting other problems, clonazepam would be the benzodiazepine that I'd recommend. It's long-acting, doesn't have a peak. It has a extended curve without the peak. Peak tends to lead to a buzz, like you see with Ativan. And the approach that I take with a patient is tell them, I don't want you above 2 milligrams a day, and most patients are around half a milligram to 1 milligram a day. And all my patients that I have on clonazepam, probably 5–10% are above 2 milligrams a day. A morning dose sometimes is necessary to guard against panic attacks, and so 0.25 to 0.5, and then a PRN dose if they have a panic attack coming. And usually that assures them that the panic attack will be under control, and then they don't have an elevated level of anxiety during the day. And so that morning dose tends to lower their level of anxiety, much like with the seizure disorder, where you lower the likelihood of developing a seizure. So Xanax and Ativan I try to avoid unless they've been on it before and come in on it. They have a greater buzz after taking it, and rebound anxiety is a problem, and withdrawal, as many of you know, is a lot harder. All right, let's go to Ms. E. This is a 25-year-old single white female medical student. 2-year history of panic attacks with shortness of breath, tachycardia, sweating, intense anxiety. They last about 20 minutes and occurring once or twice a week. She's had a cardiac evaluation. No abnormalities were found. Most of these panic attacks occur spontaneously. A few are triggered by the discussion of cancer, which is really worrisome to her because she's in medicine. There's no past or current history of depression. Options: escitalopram, 10 milligrams a day. Who would use that with her? Yes, it's a good start. No problems with it. If you have another antidepressant you're more comfortable with, that's fine. Clonazepam, 0.25 milligrams to 0.5 milligrams every morning, up to BID, PRN panic attack. Acceptable or not? Yeah. If the escitalopram alone is not successful. And so after about a month to 6 weeks, if you're not seeing a response, have gone up to 20, then clonazepam is worth trying. Sometimes you'll be pushed to use it sooner. And in this case, because of the pressure of school and the difficulty she was having, it was started earlier. Meditation, of course. Insight-oriented psychotherapy to understanding the meaning of cancer. Not really an interest of this patient. She just wanted to have the anxiety under control. And she responded. So she had probably a total of 10 doses of clonazepam worked for her as the escitalopram came into full effect. And so now 10 milligrams with PRN available in her pocket or purse if she needs it. Early dementia, the third of the topics that we're going to cover today. This can be, of course, a rather depressing illness for obvious reasons. Well, let's assume you're seeing a patient with signs of early dementia. Their workup is negative for reversible causes, metabolic, low pressure hydrocephalus, for example. Consider an antidepressant. Now, why? Well, as we talked about earlier, the normal cognitive processes of the brain help us regulate our mood and emotion as part of it, help us regulate our sleep, as we just, as I mentioned, an article that came out this week. And in the January American Journal of Psychiatry, large study found that using a Prozac-type drug for 3 years delays the worsening of dementia. And it's most effective in those that have not had depression before, suggesting that the depression might be one of the earliest signs of cognitive disturbance, along with some of the presenting symptoms of dementia. Now, what I've discovered in my practice, and now we're seeing some articles, is that these patients also respond to a stimulant. Why? Think of it like ADD. Many of the problems that patients with early dementia have are very similar to your patients with ADD. Difficulties concentrating, difficulty retaining, distraction, procrastination, and low dose methylphenidate, like we talked about before with depression, 5 to 10 milligrams once or twice a day, has significantly helped a number of patients that I've seen in the early stages of dementia. Now, it also, in patients with a little more progressed dementia, and here you might need to move to Adderall, has shown that it improves impulsive behavior. Now that's early and may turn out not to be the case as we get more information on it, but a couple early studies suggest that it might be, and as I said, you might have to switch to Adderall, which is a little bit more powerful than methylphenidate. All right, let's look over this case. 62-year-old, married, white female, retired publicist, comes in because she's having trouble writing articles. She's in the middle of the article and then she forgets what the theme is, or she can't quite tie things together. And this is how she made her career for a number of years. And so distressed about this. She also had some mild symptoms of depression, mainly around concerns about her ability to function. Retirement has not been easy for her. She hasn't had good replacement activities. But mostly her difficulty in concentrating, problems reading a book and being able to remember the characters in the book, has resulted in her becoming moody. There's no past history of depression, not suicidal. Occasionally she gets lost while she's driving. On the mental status, she can recall only 1 of 3 objects at 5 minutes, several mistakes in serial sevens. I never was very good at math, she says. And when she draws the clock face, the numbers are not proportional. They're concentrated in the first 3/4 of the clock. So some early signs of difficulty. Options: escitalopram, 10 milligrams a day. Sure, given what we were just talking about. Exercise, to be sure. Methylphenidate, yes, and she responded very well to it. Not that it reversed the dementia, but her concentrating ability improved. She is able to type shorter pieces like letters and not get lost in the middle of those, and augmented the escitalopram so that the depression isn't quite as intense and feels a bit more optimistic about where she's headed. Is it going to counteract the depression, or I mean the dementia? No, but with a little bit of luck, we'll push it back so that it's not as disabling for her for a more extended period. All right. For those of you that want to have a view of the synapse. You can't have a discussion about medications in psychiatry without a picture of a synapse, so I included one in there. I promise you we won't go over it. There's another case there, if we have time. I thought you might enjoy this cartoon. And if you didn't, at least they did. All right, any questions, discussion, cases that you'd like to go over? And if you, oops, I'm supposed to stay behind this podium. I can stick around for a while if you have cases that you want to talk about. Yes?